started. Welcome to our screencast. Thanks for joining us today. I'm Michelle, one of the POCUS Fellows at the Hospital for Sick Children. Our topic today is POCUS of the pediatric lung, and it builds upon Mark Tessaro's lung screencast a few months ago, incorporating more cases and a bit more literature. I have no conflict of interest to disclose, and our PEM POCUS rounds are now Royal College Section 1 activity, so you can get your credits by signing in with the link shown there. So our learning objectives for today will be to review how to perform pediatric lung POCUS. We'll go over 5 cases to demonstrate various applications of lung POCUS, and we'll discuss some advantages and pitfalls of these applications. So a general overview of how to perform lung POCUS, which some of you may already be familiar with. The transducer of choice in pediatric lung ultrasound will be a high-frequency linear transducer. We'll obtain 3 zones for each lung for a total of 6 views. So the anterior mid-clavicular line, the mid-axillary line, and the posterior views between the scapula and the spine. So using the linear transducer, you would scan in a longitudinal orientation into 6 views, as shown there. So anterior, mid-clavicular, and axillary. Then the same thing on the contralateral side. And then you repeat over the posterior chest. In the quick EFAST approach, let's say you're dealing with a trauma patient, you could use the ultrasound to rule out pneumothorax by looking at the most anterior aspect of the chest in a supine patient. That's usually where the air will pool. Keep in mind that despite lung ultrasound being a good screening exam, it's about 95% sensitive for consolidation compared to lung CT. But there are areas highlighted in red here that you may not be able to cover. But usually if it's in those zones, it may arguably be small enough that it may not be clinically relevant. So now you'll review, sometimes you'll see in the literature that advocates for doing all 6 views in longitudinal and transverse. But at SickKids, we teach doing only the longitudinal views for efficient screening to start. And we often do this zigzagging lawnmower technique to cover more ground so that our scans can be done in a more speedy fashion. And here's Mark demonstrating how to do the lung scan on his daughter. In younger kids, we often start in the front so that they can see what you're doing and won't be as afraid. And then you can turn them over with the parent holding the child to do the posterior views. Often the children will do this, so they'll tense up and move a lot, and it becomes a bit trickier to scan when their scapula are closed. So you want to try to open up their back by having them wrap their arms around their parents. And sometimes distraction will help by letting them watch a video of some sort. And the posterior views can be sometimes elusive to obtain, because in order to get crisp A lines, you really have to be perpendicular to the pleura. And in the back, it can be at an angle. So you really want to make sure that you are first in between the scapula and the spine in the back, and you may have to tilt your probe to be at a bit of an angle so that it's aimed slightly towards the shoulder in order to get those crisp A lines. So here's a video of normal lung, where you see at the top, usually at the pleura, you'll see normal lung sliding. And in the absence of any lung parenchymal disease, you'll see A lines, which are reverberation artifacts that appear to be repetitive and parallel to the pleura. And here you can appreciate the lung sliding at the top with like the ants crawling appearance. Sometimes you can see some comet tails. But then when there is subpleural interstitial thickening due to either fluid there or parenchymal disease, you can get these B lines, which are comet tail artifacts that are perpendicular to the pleural line and extends all the way to the bottom of the screen, kind of like a spotlight. So let's go over some case examples. We'll demonstrate 5 POCUS applications. So for case 1, let's imagine a very common scenario in the emergency department. Imagining a 2-year-old girl with cough for a week and fever for 3 days. Now, when you examine the child, she's crying a lot, so it's impossible to hear anything. And you wonder if her mild work of breathing and tachypnea is just from her being upset and febrile, or if there's more going on. So you decide to scan her lungs. And let's review a range of possible POCUS findings. So in scenario 1, this is what you see. And we don't have any trainees here today, but how would you describe the findings in this? It's kind of diffuse.
Yeah. A few behinds here and there.
A few comma-tails, and no significant
confluent
confluent B-lines.
No B-line.
You don't see any consolidation. And so in this case, you might be more reassured to just treat her fever and maybe come back in a bit for reassessment. Now in scenario 2, you see something like this, which is a small subpleural lesion that is about 1/2 centimeter. And when you see something like that, you do want to make sure that you are scanning around this lesion to make sure that you're seeing the lesion at its maximal depth. And if you're sure that it is still sub-centimeter, it could still be consistent with a viral illness. Now here's another scenario where you see a bit more focal B lines. So a little bit more suspicious, and you look around a bit more. And when you follow it, you definitely see more abnormalities later on. So you kind of see the lesion that's becoming almost 1 centimeter with the shedding and the B lines underneath the irregular border. Here's another example where on the left side of the screen, you get a bunch of confluent B lines, which could be non-specific, but then in many situations, when you're following these confluent B lines, you get true pathology, in this case, a large consolidation. Here's another example. So here the diaphragm is well visualized, just distal to the lesion on the right of the screen there, where you see that dome-shaped structure, commonly seen with 3 layers. So 2 outer echogenic layer of pleura on one side and peritoneum lining on the other, and an inner echogenic layer of connective tissue that's surrounded by hypoechoic muscle stripes. So when you see a lesion, it's important to have a look, just trace it to the top to make sure that you're seeing true pleural lining rather than something that may be below the diaphragm, in which case you would see this dome-shaped structure with 3 layers, sometimes 2 layers. So I just have a whole bunch of examples of pneumonia just to kind of demonstrate the various findings that you could have. So here's a more extensive consolidation, hypoechoic area with focal B lines, irregular borders, fluid bronchograms. Here's another one. Similar appearance. It's quite deep. One more for good measure. Another one. Mm-hmm. So here is an example of one that's starting to necrotize. You see more of that kind of border forming that's looking a little bit more loculated. Another example. More examples. And then when you see something in longitudinal, you can often turn your probe transverse to appreciate the extent of the disease within that rib level. And there are other views that we often discuss as well. One being this transhepatic view where you use a phased array probe and just around the end of that clip there, you can appreciate that around just beside the heart, you can appreciate the beginning of a lesion with irregular borders, focal B lines, and that hypoechoic lesion. You can also sometimes see it on cardiac view. So here's an example where in your peristernal short, you can see the lesion juxtaposed to it. So to summarize some pneumonia findings in the clips that we've just seen, so you could have the subpleural hypoechoic areas that's often more than a centimeter deep, being more suggestive of bacterial pneumonia. You can see hepatization, you can see air or fluid bronchograms, confluent B lines, shredding. And before we move on from pneumonias, just a word about bronchograms. So often in the literature, they discuss static versus dynamic air bronchograms to differentiate between atelectasis, which is often more described with static air bronchograms, where you can see here the air within the bronchogram doesn't really move, versus in this example, where the air bubbles within the air bronchogram often can move. And this is described as dynamic air bronchogram. And in the literature, they sometimes describe it as pathognomonic for pneumonia. But in kids, it's often more of a mixed picture. And sometimes it is also hard to appreciate when kids have such high respiratory rates. And also, we've definitely seen pneumonias that have both static and dynamic air bronchograms. So often we incorporate our findings into the clinical picture rather than using these features alone to make the diagnosis. Here's an example that instead of air filling the bronchogram, it's fluid within the bronchogram.